The broadcast is now starting. All attendees are in listen-only mode.
Good evening, and thank you for joining us. I'm Deborah Livingston, and I'm the Development Director with the Mayfield Education and Research Foundation. Welcome to our first installment of Brain Talks, our webinar series created to improve your brain health. We're picking up this evening after the Spine Talk series webinar, where we learned all about protecting the spine and treating abnormalities. Tonight, we are joined by Dr. Yair Gozal here at Mayfield Brain and Spine. Dr. Gozal will help us learn more about when to seek treatment for headaches and other related symptoms. Thank you, Dr. Gozal, for joining us this evening, and thank you to ProScan Imaging for sponsoring this talk. Before we start, let's take a moment to ensure that everyone is ready and familiar with the webinar control panel, which is located on the right side of your screen. First, you can minimize this panel by clicking on the orange arrow button in the upper left-hand corner. You can expand the panel by clicking the same button again. Second, you have the ability to submit questions using the question pane located on the control panel. If it's not open already, just click that question bar to expand it, and you will see where you can type and submit questions to us at any time, and we will answer the question at the end of the presentation. Finally, this webinar is being recorded and will post online at mayfieldfoundation.org for later reference. Now let's get started. We are pleased to have Dr. Yair Gozal join us. Dr. Gozal is a neurosurgeon here at Mayfield Brain and Spine. Dr. Gozal specializes in the treatment of tumors, trigeminal neuralgia, skull-based surgery, and complex cranial surgery. He was most recently named one of the region's best doctors by Cincinnati Magazine. Thank you for being here, Dr. Gozal. You may now begin your presentation.
Good evening, everyone. Thank you so much, Deb, for the introduction, and thank you for the invitation to join this Brain Talk series of webinars. Today, we're going to talk about headaches and other symptoms not to ignore. Essentially, we all experience everyday ailments like headaches, dizziness, forgetfulness, and they're just symptoms that we have from time to time. They normally go away on their own, but every once in a while they persist and can be more severe than usual. And when these symptoms do that, they can be a sign of a more worrisome problem in the brain. And so this talk really focuses on reviewing some of the symptoms that you shouldn't ignore and when to check them out. We're going to cover a series of topics. I'm going to start with stroke symptoms, and then move on and discuss memory impairment and cognitive dysfunction. We are going to then move to discuss headaches and dizziness, and finally talk a little bit about head injury because of the importance that this carries nowadays in terms of public health. So as I mentioned, we'll start with stroke. Stroke is a huge problem. It is the 5th most common cause of death in the United States annually. And it's one of the primary reasons to have a functional problem or a neurologic problem. And it tends to affect about 800,000 Americans annually. The issue with stroke is that there's a blockage in one of the arteries, and it prevents blood from arriving at the brain. And that area of the brain that normally receives that blood then becomes ischemic or doesn't get enough oxygen, and it tends to die. And it makes sense that if you can restore blood flow to that area as soon as possible, you can save as much brain as possible. And so we talk about time as brain. The sooner you can restore flow, the better. And so we've come up, or there's been a shift towards using this mnemonic called FAST to remind people what the symptoms of stroke are normally. So the F in that mnemonic FAST includes facial drooping. So one side of the face is asymmetric to the other. You can ask a person that you're concerned about to smile and see if their face is symmetric. The next is the A, that stands for arm weakness. And so oftentimes we'll ask a person to lift their arms and see if they're able to do that evenly. The S stands for speech problems. The patient's able to speak. Are they able to answer questions properly? Is the speech slurred? And finally, if these are the symptoms that you see a person that's experiencing, it's critical to call 911 in time to intervene on these symptoms. And the mnemonics actually expanded over the last few years to be fast because of the two other symptoms that are often seen in stroke, including imbalance, patients having trouble walking straight, falling over, and then losing vision. Having one of the harbingers of an early sign of a stroke and a sign of a more severe stroke to come is a symptom in which you can have a shade or loss of vision in one eye. So it feels like a shade's coming over that eye and you're losing vision in that eye. And oftentimes that sight is restored, called amaurosis fugax. And it can tell you that there's a bigger stroke that's upcoming and to go seek help. There are really two types of strokes. There are hemorrhagic strokes or bleeding types of strokes. They're called intracerebral hemorrhages. And that's when you have a small vessel that's inside the brain that hemorrhages and creates a hematoma. And not only is the blood that's normally delivered by that small vessel not getting to where it needs to go, but the hematoma itself can displace the brain and cause pressure on areas that normally would be functional. And that can cause symptoms of a stroke. The other type of stroke is called an ischemic stroke or a blockage type of stroke. And that's when you have a blockage due to either atherosclerosis or plaques from that, or a blood clot that travels in and gets lodged in the vessels and prevents blood flow distally in those smaller vessels. And when that happens, blood isn't delivered to the brain, the area where the vessels are going. The brain becomes ischemic or oxygen deprived. And that part of the brain can, if it lasts sufficient time, can infarct or die. And for those strokes, the ischemic type of strokes, there have been several treatments that have come up over the last couple of decades. One of them is the administration of a drug called TPA. It's tissue plasminogen activator, and it's given IV. And it goes in the vessels to the area where there's a blockage from a clot, and it breaks down the clot and restores normal flow. And this works extremely well, and it does have some limitations, particularly that it needs to be used between 3 to 4 hours or 3 to 4.5 hours of the onset of stroke symptoms. So if you're waiting or don't arrive in time, you may not be able to receive this medication, because after that time period, you can have several complications, including bleeding as a result of the administration of the medication. In the last decade or so, there's been tremendous progress in another way of treating ischemic strokes, and that's something called thrombectomy. If you have a sufficiently large vessel that's occluded, an endovascular surgeon can actually pass a catheter directly into the vessel and pass it up to the area that's blocked off, and then deploy a device that captures the clot and pulls it back into the catheter and then pulled out. And that immediately restores flow. This is an amazing treatment. It restores flow in these big vessels, and because of that, it oftentimes can get people significant symptoms, or they get their significant symptoms to improve and get them fully functional, in fact, especially if it's used earlier. The nice thing about this is that there's data that shows that it can be used up to 16 hours after stroke begins. But remember, the longer the stroke is there and the longer the blood isn't delivered, the more brain dies. So the sooner it's deployed, the better it is and the better outcomes people experience. Better than just treating strokes, it's probably better to try to prevent them in the first place. And in order to reduce your risk of strokes, we recommend a number of different things, including controlling your blood pressure, controlling your blood cholesterol. That prevents damage to the vessels. Similarly, controlling your diabetes, which affects small vessels, can help improve or reduce your risk for stroke. Certainly not smoking is an important component of preventing stroke. Avoiding obesity and getting regular exercise are also key. Cardiovascular exercise reduces your risk of stroke by different mechanisms, and so that is a critical component of that. And finally, just be aware of atrial fibrillation. If you do have atrial fibrillation, that's a condition in which the atria of the heart move in a chaotic rhythm, the blood flow doesn't pass through there well, so blood pools and tends to clot, and then clot can dislodge and go to the brain and cause a stroke. So patients with atrial fibrillation can be placed on prophylactic medications that thin the blood, called anticoagulants, and those prevent the formation of clot, and then they prevent stroke by doing that. So there's no clot to go up to the vessel to the brain. In today's climate of COVID-19, I wanted to touch base on the fact that even though there is a tremendous fear of COVID-19 and going to the hospital, people should not delay going if you do experience stroke symptoms. There's a paper published recently in the Journal of Neurointerventional Surgery. Actually, one of my partners, Dr. Ringer, contributed to the study that discussed delayed presentation in stroke during COVID-19, and it showed that patients ended up showing up to the hospital about 30% later than they have prior to COVID. And obviously 30% is pretty significant in terms of how much brain you can save. Remember that time is brain. The next topic I wanted to cover today is memory impairment and problems with thinking or cognitive function. Now, we've all forgotten where we've placed our keys or what day of the week it is, and then remembered later, but and that's a normal component of normal aging. When the memory loss or other dysfunction affects your ability to complete your day-to-day activities and just get the things that you normally have to do done, then you start talking about more severe cognitive dysfunction and potentially even dementia. And there are multiple types of dementia. I'm going to cover just a couple very briefly so people have an idea of what those are, but we'll talk today about frontotemporal dementia, vascular dementia, and Alzheimer's disease. So the brain is just an awesome organ, and it changes dramatically throughout your lifetime. And when we're born, we're started with these big brains, as you can see here on the left. That's a normal brain looks like. And we start with very large brains as infants and continue to make synaptic connections, and as we learn in our early years. But after about the age of 20, we start losing neurons every year to the tune of about 9,000 or 10,000 neurons a year. And that doesn't sound like too much, but it certainly adds up over time. And that's called brain atrophy. And over the course of your lifetime, you could lose 10 to 15% of the mass of the brain and see that the brain shrinks, in particular in areas that are critical, like the hippocampus involved in memory, or the frontal lobe that's involved in cognitive processing and personality. And as the brain ages and shrinks, people find it more difficult to remember where they left their keys, remember certain words in conversation, recall people's names. Multitasking becomes more difficult, and certainly attention to certain tasks becomes also very difficult. And again, when it becomes quite severe, where it affects your activities of daily living, it affects your ability to balance your checkbook, to do the things that you've done your whole life, it gets to the point where you have severe cognitive impairment, and it's called dementia. And dementia is really an umbrella term that's used to describe a whole range of different conditions. Most of the difference between them is pathologically significant, but in terms of how they present clinically, really depends on what the first symptom is. Ultimately, they progress to all kind of get to the same point. But in Alzheimer's disease, you start with memory dysfunction, and in frontotemporal dementia, you start with changes in personality or speech. Ultimately, though, in frontotemporal dementia, patients do develop memory dysfunction as well. And similarly, in Alzheimer's disease, it tends to affect your personality as the disease gets worse. We'll start with vascular dementia. So this is an interesting one because it's very common, and it normally occurs the decline occurs in a very stepwise pattern. And the reason it does that is because people develop multiple small strokes, and initially you tolerate that, but ultimately you lose the brain's reserve, or the strokes happen in functional areas. And so you have a little stroke and you have a little bit of worsening in your cognitive function or being able to accomplish certain tasks. And then you have several months go by and you have another little stroke and then another little stroke. And so you have the stepwise pattern of decline until you're essentially not able to care for yourself anymore. In frontotemporal dementia, as the name suggests, you have atrophy or loss of the frontal and temporal lobes. And in this condition, and again, there are various types of frontotemporal dementia, but in this condition, it really depends on what breaks down first. And in one variant, the frontal lobe variant, you have patients that have personality changes because that frontal lobe is critical in personality. So they become disinhibited. People who are normally behaved before, they start gambling, spending money, overeating, doing a lot of repetitive or obsessive behaviors, and that's because of atrophy of the frontal lobe. There's also a aphasia variant, or a variant in which people have difficulty with speech and finding the right words, and that has to do either with area called Broca's area or breakdown of the temporal lobe. But in those patients, they just have difficulty either generating or understanding speech and interacting with people. Ultimately, in frontotemporal dementia, especially as the temporal lobe breaks down, people will have also a loss of memory as well. I do want to point out that frontotemporal dementia tends to start younger, affecting people that are 45 to 65 in age. And that's younger than Alzheimer's disease that tends to start at the age after 65. But in certain familial forms, you can get pretty early onset. And in Alzheimer's disease, as I've mentioned, the key here is that memory loss is the first symptom. And so patients have difficulty remembering where they've placed their possessions, they get lost, they have trouble remembering people or conversations that they've had, and they get to a severe point where they actually forget their family members or everyday objects and become apathetic. They have significant behavioral changes at that point, and that's when the dementia really progressed. I wanted to highlight in this slide that there's normal mild cognitive impairment or age-related changes that take place, and that again is making bad decisions. You may forget what day it is, but remember that later. Forget a word while you're giving a talk, for example. But in dementia, that becomes significantly more severe. Those are people that just can't balance their books. They forget to pay any of their bills. They don't shower. They forget to take their medications, lose track of what day it is entirely, can't even hold a conversation. And I did want to point out as well that there are other symptoms that can contribute to how severe dementia appears or to make people look more cognitively impaired than they are. And for example, vision loss, and in particular hearing loss, can have that effect. So people who have hearing loss, for example, will sit in a room and they're unable to participate in the conversation. That creates intense loneliness, of course, where they can't interact with people. They're asked questions and it seems like they're unable to follow the conversation, they seem confused. But that may entirely relate to their hearing loss, which then subsequently actually makes them more susceptible to developing dementia. And so it's critical, if you're having symptoms of cognitive decline, to go get checked out, because if it is something like hearing loss, it can be corrected. You can actually stem the progress of the cognitive changes. Now, the next topic is headaches. And everybody gets headaches. In fact, 75% of Americans said they've had a headache within the last year. The vast majority of them are not urgent, but it forms the second most common reason for people to go to the emergency room. And although 90% aren't urgent, there are some situations where headaches are urgent, and we'll start with one of those examples. If somebody suffers an abrupt, sudden onset headache that often is associated with stiff neck or vomiting, we start being concerned about what's called a subarachnoid hemorrhage, or a hemorrhage as a result of aneurysmal rupture. It's often described as the worst headache of life. And It occurs when you have an aneurysm or an outpouching in a vessel. As you can see here, there's a vessel, and then the outpouching is here. It's a weakness in a vessel wall, and it kind of forms this pouch or weak walled area that then can rupture. It's kind of like an old hose. An old hose can do the same thing and then leak in that location. The same thing happens in the blood vessels, either due to a problem with the vessel wall itself, or atherosclerotic buildup, or sometimes with smoking, causes damage to the endothelium and can cause this. And you've seen this slide before. It talked about the different types of strokes. The subarachnoid hemorrhage, that's a large vessel that has this aneurysm, as you can see here, and the blood ends up collecting not inside the brain, but around it in the space where the vessels travel, the subarachnoid space. And in the situation where you do have a ruptured aneurysm, that's a very serious condition. You can have kind of an initial bleed and have the severe headache and make it to the hospital okay. The key is going to the hospital when you experience that, because 10 to 15% of people don't make it. They die before arrival. And even after people make it at about a month, only about 55% of people survive aneurysmal hemorrhage. So it's critical to get to the hospital if you have that sudden onset, what we call thunderclap headache, worst headache of life, and especially if it's associated with other symptoms like nausea and vomiting. And the reason to get to the hospital is because once the lesion is identified, we can treat these aneurysms, these ruptured aneurysms, by securing them and keeping them out of the normal circulation. And there's two ways to do that. One is surgically, where we open the skull and find the aneurysm itself and actually put a clip around it. And by putting the clip there, you prevent the blood from filling that aneurysm and spilling out into the subarachnoid space. The other way to do that is from within the vessel, and that's called coiling, and it's done by an endovascular surgeon who passes the catheter all the way up to that vessel, finds the aneurysm, and then places coils within it to create a thrombus or a clot in that area, and that prevents blood flow from going that way. There's also stenting now, and this technology has just really taken off in terms of what kinds of aneurysms can be reached and can be treated in this way without proceeding to a craniotomy. The other headache that is important that I wanted to cover today is a morning headache, or a headache that's worse after laying flat, a headache that tends to wake people up in the morning, and often is aggravated by coughing, sneezing, or straining, and can be associated with other worrisome symptoms like nausea and vomiting. These types of morning headaches essentially predict that or occur when people have elevated intracranial pressure. That is, the skull itself is a closed space. The brain is in there, and there's blood and spinal fluid. But if you have a tumor or hemorrhage or too much spinal fluid, it can actually cause pressure on the brain itself and give you this type of morning headache. When you're laying flat, that is overnight, the pressure in the head goes up, and so that's why people often will wake up with these types of headaches. And the same thing happens when you're coughing or sneezing or straining. The pressure in the head goes up, and if it's already pretty high, that can result in a pretty severe headache. You can see here is an example of where there's a tumor, a large tumor in blue, that's pushing in against the brain. The brain is confined to the skull. Because blood and spinal fluid are fluids, they're non-compressible, so the only thing that gives way is the brain. And the tumor then continues to grow and increases the pressure, and this will give you those morning types of headaches, although it can cause headaches outside of that as well. So in terms of headaches, not to ignore, if you have very severe sudden onset headache, or if you have chronic headaches that just aren't getting better, it's worthwhile getting checked out. Particularly if those are associated with other symptoms like nausea or vomiting or pain elsewhere, fevers. Certainly, it's important to go see a physician, and oftentimes you can go in the emergency room if it's after hours. There are numerous types of headaches that can be chronic. The headaches kind of come in two flavors. There are primary headaches. Those are headaches that start within the brain, like migraine headaches or cluster headaches or tension headaches. And there are secondary headaches that are caused by other symptoms like a tumor that's forming, or elevated blood pressure, or something called hydrocephalus, too much spinal fluid in the head. So there's secondary headaches just have another reason to cause it. Regardless of the type of headaches that you have, if they're chronic, it's worthwhile getting checked out, because the majority of these have some way of managing them that will make you more comfortable in the long term. We talked about the thunderclap headaches. Those are the potential subarachnoid hemorrhage, but also, as I mentioned, cluster headaches, exertional headaches are important to get checked out. Tension headaches and migraines, there's been a tremendous progress in the types of migraine medications and the management of migraines. And then it may not be that you need to see a neurosurgeon or a neurologist for that. There are certain headaches that your primary care doctor or in the emergency room, if you come in for those, you'll get referred to see other specialists like ENTs, for example, with sinus headaches or allergy type headaches. The next topic is dizziness, and really dizziness and vertigo. And I wanted to touch on this because it's an extremely common symptom. And so there's a difference between dizziness, where people essentially feel like they're either imbalanced or feel lightheaded. People describe that as dizziness a lot. And vertigo, where you feel that the room is spinning around you. Dizziness has many, many, many causes. In fact, neurologists and ENTs, that's one of the most common complaints that they get. And one example of why somebody would feel dizzy is a condition that has nothing to do with the neurologic system. It has more to do with the blood pressure, something called orthostatic hypotension. And that's a very common reason for particularly older adults to feel woozy or lightheaded or even fall. And this occurs when you first stand up. The first few seconds when you're up, you feel lightheaded. And then after a few seconds, you kind of catch yourself and you're able to walk. And that occurs because normally when you stand up, the heart starts to pump more blood to the brain because of because gravity and the change in elevation. And the arteries will squeeze down and increase the blood pressure a little bit to allow blood pressure to get to the head. And as you get older, there's hardening of the arteries due to vessel damage over time. And that reflex doesn't happen as quickly. And so when you stand up, the amount of blood that's going to the head drops a bit, and you feel lightheaded and woozy. And that can actually cause falls. And just as an example, certain types of dizziness, including that caused by hypotension or orthostatic hypotension, can be treated. And that can be treated often with preventing dehydration, or even addressing the types of high blood pressure medications that someone is taking. In terms of vertigo, vertigo is again a symptom that you have when the room is spinning around you. And that often happens because of an inner ear problem. And there are various causes, again, of vertigo. The most common are things like viral illness, but one of the common ones that we see is called benign paroxysmal positional vertigo, or BPPV. And that happens when these crystals inside the inner ear get dislodged, and as they move around, they stimulate the nerves, and it tells the body that you're moving, but in reality, you're just standing still. That asymmetry between moving and your brain thinks you're moving, but your body is actually standing still, makes you feel like your world is spinning around you. And again, this can result in falls, can result in trauma to the brain as a result of a fall. But again, these are things that if you have, they're typically severe enough, they can be associated with nausea and vomiting, but they can be treated. And so it's important that if you're experiencing a lot of dizziness or vertigo, that you seek help, because correcting that will prevent a trauma or can prevent a car accident, especially when these episodes happen unexpectedly. And the last topic I wanted to discuss today is head injury. Head injury has become, it's really been a huge public health problem for many years, but it's now more in the media than ever, particularly with sports. In younger Americans, the primary cause of head injury is something hitting you in the head, whether it's playing sports or getting in a fight or something like that. In older Americans, it tends to be the primary cause of head injury is falls or motor vehicle collisions. And it affects up to 2 million Americans annually. And the severity of head injury ranges between the least severe, which is called concussion, to very severe traumatic brain injury. And even within concussion, there are grades. And what defines a concussion is when you've had a trauma, but if you look on CT or MRI, there are no changes to the brain itself that you can see by those methods. It doesn't mean that there hasn't been an injury, but you can't see anything on the studies. As soon as you can see any bleeding or bruising of the brain, it becomes a mild traumatic brain injury, moderate, or severe, depending on how affected the patient is. Most of the traumatic brain injuries happen because the brain is not perfectly fit in the head. There's fluid around it, and if you suffer trauma, the brain kind of moves around and can be either strikes the skull or starts to turn or to rotate or tear some of the nerve fibers that are normally there that are passing through. And depending on where that happens, it can result in functional impairment after, and what we call a brain injury or traumatic brain injury. I'll focus a little bit on concussions. Some of the signs of concussions that occur, say you suffer a fall, or your son or daughter is playing sports and gets hit in the head. We're very familiar with these. You can have a loss of consciousness. Person becomes disoriented. They have a dazed or vacant stare. That's where the stars around the head comes from in cartoons. Have incoherent speech or memory loss, being amnestic or not being able to remember the actual trauma, the event afterwards. Those are typical signs of concussions, and you don't want to miss those because it has implications about whether you should return to play, return to work immediately, or go seek expert consultation. The symptoms of concussion are also important to know. You can have headaches or dizziness. Those are actually the most common. You can have tinnitus or ringing in the ears. People tend to sleep a long time as the brain recovers. Sensitivity to light is very common, and nausea and vomiting, for example. And so if people are having these types of symptoms, they're not over the concussion or under traumatic brain injury, and they should be very cognizant of the fact that they're still limited in what they're allowed to do. The key to recovery from, if we just focus on concussion, the key to recovery is to rest. Time does heal these concussions. Normally for concussions, the symptoms go away within 1 to 2 weeks. In rare cases, particularly with dizziness and headaches, you can have them for long periods of time, and then we do typically refer patients to see specialists who deal with mild traumatic brain injury. But the key is recovery, so avoiding a lot of high sensory input, so watching TV, looking down at your phone, loud places, going out, essentially stay away from people and try to get as much rest as possible to rest your brain. If you're, in terms of work, you don't want to tax your brain too much. You can do partial days or take time off before you go back to work. And same thing with school. If it's a child, it's important to just reduce the amount of input that you're getting to allow your brain to recover. In terms of returning to the field, if it's a sports injury, or if you've had an injury in another way, say a fall from a bike, and then you want to return to a football game or some other sport, it's critical to not have symptoms for at least 24 hours. Having all the symptoms that we mentioned here resolve before even considering going back. And the reason this is so critical, because some people can kind of fight through it, is because if you're still having symptoms, you haven't recovered completely. And a second traumatic brain injury that, of course, is not on purpose, it's inadvertent, but a second traumatic brain injury can have real significant consequences in terms of how the brain responds. It can respond in a more aggressive way, including swelling, and can cause death to have a repeated injury so quickly after the first. And then I wanted to also talk about brain hematomas called subdural hematomas. These are hematomas that occur as a result of trauma. Primarily, they don't have, that's not the only way, but that's the most common way. And what they are is, so there are these veins that are attached to the covering of the brain, and they come down and they attach to the brain as well. They're called bridging veins. And when somebody suffers a trauma and the brain moves forward or backwards, you end up tearing these types of veins, and it causes bleeding. And typically, it'll bleed for a little while, and then it will stop bleeding, and the brain's able to absorb the blood that's there. But particularly with people on anticoagulants or older individuals, sometimes it can continue to bleed for a while and create a pretty significant hematoma with brain compression. And this is much more common as we age because, as I mentioned earlier in the talk, the brain shrinks away from the skull. Means that those bridging veins are stretched, and even a minor trauma, as the brain moves away, can tear a vein. And then you collect the blood in that area, and that stretches the other veins around it even more, and then another mild trauma can cause further bleeding, and these just continue to grow and collect and press on the brain. So if people develop persistent headaches after a trauma, or if you start seeing the symptoms we discussed earlier, this relate to stroke, weakness on one side, facial drooping, speech problems, it could be a harbinger of also having a subdural hematoma. And so they need to come in and to the hospital and be evaluated, get a CT scan, identify that. And oftentimes we can evacuate these, particularly if they're older and they're liquid, you can evacuate them with just a small opening in the skull. Sometimes, though, they can be managed without surgery as well. The last thing I wanted to cover is the 6 pillars of brain health. This is the pillars of brain health it was borrowed from this healthybrains.org website. I believe it's part of the Cleveland Clinic. But I like the way they had things laid out because it's not just about identifying symptoms and reacting after bad things happen. It's also about making sure that you maintain your brain health and do the things that you can do in life to keep yourself from developing dementia or putting yourself at risk for stroke in the long term. And so the first pillar of brain health is maintaining your medical health, and that makes a lot of sense. I think a lot of these are just common sense, but it's important to highlight them. And so if you do have hypertension, making sure that your blood pressure is well controlled, same thing with diabetes. Not smoking is crucial both for stroke risk and for dementia. Obviously, maintaining good body weight, and then avoiding high cholesterol. All these things, and certainly depression also increases your risk of dementia. So the normal things that you have, the diagnoses that you have, trying to manage them in the best way you can to decrease your risk in the long term. Maintaining social interaction is key. Loneliness is bad for the brain. So people who are married, people who have children, interact with their children, people who are active in their communities, who go to church, those people constantly engaging their brain in a social setting, and those people have a lower rate of dementia and may clearly that provides a protective benefit to have those interactions with other people. This actually goes back to the point I made about hearing loss, for example, where people become isolated because they can't interact with people in their environment. And so, again, if you do have hearing loss, it's an important thing to have corrected because a hearing aid can make a world of difference in terms of how the brain responds. Nutrition is the next step. Having proper nutrition is crucial. Avoiding sweets and pastries and fatty foods, certainly very important. There's some talk about Mediterranean style diets being best for the brain because of the omega-3 fatty acids that are in fish and whole grains and green leafy vegetables, how they have a positive impact on the brain. There's some evidence that supports the reduction of certain types of dementias as a result of eating this type of diet. Sleep is crucial in terms of maintaining brain health. There's a significant correlation between being able to maintain good memory and to have to sort of codify the memories for the day whenever you're sleeping. Therefore, it's important to have proper sleep hygiene. We see that older people actually have worse sleep patterns as they age, and that certainly plays a role in how they progress towards cognitive impairment. So avoiding screens at night, going to bed at the same time every day, that can help offset some of the normal decline in sleep that we get as we age. So this is the crucial part of maintaining proper brain health. Then mental fitness, we all have heard, if you don't use it, you lose it. So again, if you don't use your brain, you're going to lose more of it. And so really being engaged, reading, developing new skills, hobbies, just pushing yourself to continue to learn, builds a reserve in the brain that allows you to lose more and more before you actually see a functional deficit. And finally, good physical fitness. We've touched on that in a number of different ways, but cardiovascular exercise has been demonstrated to reduce the risk of stroke. And these things overall keep you more mobile in life and keeps you from being more isolated, builds good relationships with others, and really makes a difference in the long term. Those are the 6 pillars of brain health. I'll take any questions.
Great, thank you so much. That was wonderful. Let's see. Okay, look, so we have a number of questions. Okay. I'm a brain aneurysm survivor and read that there is something referred to as centennial headache, which precedes a rupture, i.e. different from the worst headache of your life, that occurs during the rupture. Can you explain what this is and how someone can distinguish the centennial headache from an ordinary headache?
Yeah, so sentinel headaches are a situation where you have a small leak of blood from the aneurysm wall, and I can actually see if I can go back to that earlier in the talk. So here, we'll go here. So instead of a full-out rupture where you have a ton of blood filling out and streaming out around the brain in that subarachnoid space, you have a small area that starts to leak just a little bit of blood. And the brain absolutely hates having the blood flow around it, or that little bit of blood around it. It really irritates the brain. And so you end up with that severe headache, but you're doing relatively well. You feel okay. You might not have the associated nausea and vomiting, all the things that you think of, even a neurologic deficit that you might have with an initial rupture of an aneurysm. And so it's called a sentinel hemorrhage because it gives you a sign that something bad is going on and gives you an opportunity to come into the hospital sooner than a devastating hemorrhage would. The headaches tend to be sudden and persistent still, and very intense, but it's not quite as severe. And it's thought that actually sentinel hemorrhages, these milder forms of subarachnoid, can occur somewhere between 20 to 60% of patients. So we don't know why they have just a small amount of hemorrhage during those times, but it's a harbinger for a much more severe rupture to come, and it behooves people to come in and get treated during those periods.
Okay. Can you review again the differences between SAH, ICH, ruptured aneurysms, and hemorrhagic stroke?
Yeah, so that's perfect. So this is the right slide for that. So there's a difference between subarachnoid hemorrhage, and the real difference is where does the blood collect, and certainly why does it collect in those spaces. And so with subarachnoid hemorrhage, you have a large vessel like this, the carotid artery right here, which then splits into 2 also smaller but important vessels. And so you have this aneurysm here at the carotid terminus. And that aneurysm ruptures, and it sits in the subarachnoid space. That's the space between the brain and the other covering of the brain, part of the meninges, called the arachnoid. And so it's called a subarachnoid bleed because it collects between the brain and the arachnoid. And that area of the brain is outside of the brain itself. An intracerebral hemorrhage, or a hemorrhagic type of stroke, happens within the brain. The bleeding occurs actually inside the parenchyma or inside the brain matter itself. And that typically happens from much smaller vessels. It's typically associated with high blood pressure and damage to small vessels over time. And the problem here is more that some of these vessels are critical, so losing them can cause important symptoms, but even more so, this hemorrhage starts to collect inside the brain and push out on the fibers that pass through that area that could be critical for function, either moving or sensation, and that's how they cause their deficits. The other thing with subarachnoid hemorrhage that I didn't mention is it increases your risk for seizures. It irritates the brain cortex, which is the outer layer, the gray matter of the brain, increases your risk for seizures. And actually, people have found that it affects the normal blood flow in the area of the cortex here, in the small vessels that feed the outer portion of the brain. And that in and of itself can cause some dysfunction and ischemia in that area. And then the final type of stroke is an ischemic stroke, that is a blockage type of stroke. And that can occur for a number of reasons. The biggest one we talk about is having a blood clot that travels and gets lodged, and then blood flow can't pass through there, which is why the devices I talked about try to restore, or the medication, the TPA, try to restore blood flow in those areas by pulling out the clot or breaking down the clot. Obviously, those mechanisms, those treatments don't work for an intracerebral hemorrhage because you want a clot to form. You don't want this to continue to bleed inside the brain itself. And administering TPA, for example, would cause more bleeding in this area, not less. So it's important to know what kind of stroke you're treating, or if you're treating a subarachnoid hemorrhage, in order to use the right treatment and address the problem.
Great. I'm a survivor of a coiled brain aneurysm. Is there any after effects years later due to the surgery with a stent or because of the pressure on the brain from the ball of coils?
So generally not. You're talking about a very small amount of coils that form into this aneurysm, little aneurysm that forms here. And so let's just talk about stents for a second. The stents are devices that get deployed inside the vessel wall, right? And ultimately, the body looks at, initially, there's a high risk of thrombosis or blockage of the stroke by forming a clot inside of it, because it's a foreign material that's inside the blood vessel. And so the endovascular surgeon puts the patient on medications that prevent clots from forming, antiplatelet medications. And they do that for a certain period of time until the body starts to form a layer of cells that's sewn over the top of the stent. It's called endothelializing the stent. And that formation kind of excludes the stent. It keeps the shape of it and keeps the place open, but it prevents the body from recognizing it as a foreign object. And so in terms of the stent, no, in the long term, your body kind of sees it as its own because it's covered up and hidden away. In terms of the coil itself is secluded from the normal blood flow, and the body really doesn't do anything with it. Now, if in certain spots, like right next to the brainstem with a basilar aneurysm, if it's a giant aneurysm that you're filling with coils, it's already causing some mass effect just by the sheer fact, like even before you put the coils in, let's say it was this big, well, it's putting a lot of pressure on the brain in that location. And it might be that coiling is not the best way to treat that because it doesn't reduce the mass effect or resolve the symptoms that the mass effect of that large aneurysm would cause. And so filling it with coils would be probably the wrong thing to do. It'd probably be better to go in there surgically and exclude it from circulation and remove that mass effect on the brain. But generally, if somebody has chosen to coil your aneurysm, it's typically a small enough lesion that they're not throwing a lot of coils in there. It doesn't become a very large thing that's pressing on the brain or doing anything.
Okay, great. What percentage of aneurysms occur inside the subarachnoid space? Are ruptures in this space more life-threatening than ruptures outside this space? Can aneurysms occur any place in the brain?
That's a very interesting question, actually. So the key in subarachnoid hemorrhage and in the mortality of aneurysm or from aneurysm rupture is whether or not the aneurysm sits in the subarachnoid space or not. there's an area as the carotids are in the neck. So say you can develop aneurysms in the neck, and if it ruptures in the neck, it can cause a very large hematoma, and certainly it can be very uncomfortable and cause pain, but it's probably not going to kill you. And if it goes up and the artery actually enters the skull here and comes around and comes into the area called the cavernous sinus, which you can see here, even here, it's outside of the subarachnoid space. So if it ruptures in here, it can cause something called a cavernous carotid fistula, and can cause pressure on the eye, and cause a number of interesting symptoms, but it probably won't kill you. And so we're less aggressive about treating aneurysms for the most part, depending on their size and if they're changing, in the neck or in the parts of the skull that are outside the subarachnoid space. And the artery travels, we name the artery in different segments of the artery, and once it passes the clinoidal segment, which then enters the subarachnoid space, that's this turn that it makes right here. Now it's in the subarachnoid space, and an aneurysm in that space can cause pretty severe mortality or disability. And that's because the blood then flows into the subarachnoid space, and there's nothing to tamponade it around it to keep it from bleeding anymore. It bleeds around the brain, and it causes all those dysfunctions, or all the problems that I mentioned earlier about having blood in the subarachnoid space. The brain really hates it when it's there, and it becomes extremely irritated as a result. And that's why you have that severe headaches and the nausea and the vomiting and just the terrible symptoms that you experience. So it makes every bit of difference whether the aneurysm sits right there or right there, even though they're very close to each other. One of them is inside the subarachnoid space and one of them is outside the subarachnoid space, and it's a world of difference in terms of how dangerous they are.
Okay, great. Are daily headaches common after a coiled ruptured brain aneurysm?
So you can have headaches after any types of neurosurgical procedure. You can have headaches without a neurosurgical procedure. You can just develop them. Having coiled aneurysm can cause headaches for sure. A lot of it depends on, because the vessels themselves do have some sensory fibers that are typically trigeminal in origin. That is one of the nerves in the brain. But they have sensory fibers, and the stretch that you put on that aneurysm coil could theoretically cause headaches. I would imagine that they would resolve over time. I wouldn't expect it to continue to be an issue long term. But yeah, no, I think that it's possible to develop them, absolutely.
Okay. Where do Chiari type headaches fall in all of this? Is there a higher risk for stroke because of it?
So the answer for the second part is no, there's not a higher risk of stroke. I'm trying to pull up this picture here, or this is probably the best example of what a Chiari headache would be. So Chiari headaches are headaches that occur as a result of a Chiari malformation. A Chiari malformation, you have a portion of the cerebellum which sits here underneath the brain. The bottom portion of it is called the tonsils of the cerebellum, not your tonsils in the back of your throat, but the tonsils of the cerebellum. And they come down through the part of the skull called the foramen magnum. The foramen magnum, as the name is in Latin, is just the big hole. It's the big hole at the bottom of the skull. And some anatomists decided to name it that, just I guess to be funny, but it really is a descriptive term. It allows the brainstem and the spinal cord to come out of the skull and go down into the spine. And sometimes a portion of the cerebellum, especially when the back of the head, this occipital area, suboccipital area is too small to accommodate the cerebellum, a portion of the cerebellum would come down alongside the brainstem and kind of fill the space outside of the foramen magnum. And so what that does is it prevents normal cerebral spinal fluid flow around, from inside the brain out to around the brain and around the spinal cord. And so in those situations, you have an increase in pressure around the brain, and you can develop these types of headaches where coughing, sneezing, straining irritates and results in very severe headaches. These headaches tend to be more occipital, or in the back of the head. So they hurt in the back of the head, stiffness in the neck, and then people worsen with coughing, straining, sneezing, laughing. Heartily laughing is the same thing, because all those things increase the pressure just a little bit, and you're kind of running at a high already. And so they do those things and they develop severe headaches. Every time you laugh, or increase the pressure, maybe a little bit of the tonsils come down just a tad and causes just a little bit more blockage in that area of the foramen magnum, and that results in those types of headaches. So no, it cannot increase the risk of stroke because it doesn't affect the blood vessels necessarily, but it can be very painful, and it does kind of show up more of these morning headaches, and the same concept of these morning headaches, just increased intracerebral pressure, because there's reduced flow of spinal fluid outside of the head.
Okay, great. Can stents fail over time or get clogged?
Yes, particularly early in the first 6 months or so. And we know that from the cardiac literature as well. There's nothing magical about our neurosurgical stents, although how porous they are changes depending on the application. But yes, the device gets deployed and you have a stent placed, whether it's in the head or in the heart, or elsewhere for that. You can have it in your legs deployed as well. The vascular surgeons use that all the time, just the regular vascular surgeons, not the neurovascular surgeons. And then almost always you need to be on some sort of anticoagulant, specifically an antiplatelet medication to prevent thrombus and clogging of that stent. If you get to the point where that stent is fully covered and endothelialized, then the likelihood that it thrombosis or blocks off over time is much, much less. But I guess theoretically at that point, it's less likely to get blocked off, but it can always actually get blocked off. It's just it would be from a normal mechanism of a blood clot being delivered there. So like an embolic type of blood clot, so a blood clot coming from somewhere else that gets lodged in that space, but not from the stent itself thrombosing off.
Okay, great. It looks like that was our last question, and we're coming right up at 7 o'clock, so perfect timing. So thank
Great.
you.
Thank you, everyone.
Thank you. So I think that's going to wrap up our Q&A period. Again, this webinar has been recorded and will post on our website shortly. We hope you enjoyed tonight's presentation. If you enjoyed this evening's presentation, please register for our next program on March 9th, where we will learn from Dr. Andy Ringer. Dr. Ringer will help us understand the connection between the heart and the brain. You may register for the Brain Talks program at any time, as well as view our presentations on our website, mayfieldfoundation.org. For more information about our Brain Talks or our past Spine Talks, or the work of the Mayfield Foundation, please visit our website, mayfieldfoundation.org. And I'd like to thank you again for joining us and hope you have a nice evening. Thank you.